a special webinar through the O'Brien Institute. I am Dr. Pam Roach, so I am the current acting scientific director for the O'Brien Institute, as well as an associate professor in family medicine and community health sciences here at the University of Calgary. But before we get started, I'd just like to thank you all for joining us online today. We've had a great response to this seminar and really appreciate everybody taking the time to join us. And before we start, I'd just like to acknowledge that those of us who are in and around Calgary, which is where I'm joining from today and where the O'Brien Institute is located, are on the traditional and present day territories of the people of the Treaty 7 region in southern Alberta. That includes the Blackfoot Confederacy, comprising the Siksika, the Piikani, and the Kainai First Nations, as well as the Tsuut'ina First Nation, the Stoney Nakoda Nations, including Chiniki, Bearspaw, and Goodstoney First Nations. And the city of Calgary is also home to the Métis Nation of Alberta, which is my nation, so welcome. Today, I'm very excited to introduce Dr. James Reynolds. Dr. Reynolds is a professor emeritus at Queen's University in Kingston, Ontario. His interdisciplinary research program of over 35 years has included both basic and clinical investigations on fetal alcohol spectrum disorder. Dr. Reynolds led the FASD research program in the Kids Brain Health Network from 2010 to 2020 and served as the network's chief scientific officer from 2018 to 2024. So super excited, very fortunate that you're able to join us today and looking forward to sharing some examples of your work and some information about the Kids Brain Health Network. Just for the participants, just to let you know, as you can see in the chat, you won't be able to post questions in the chat, but you can use the Q&A function to submit your questions, and you can do that at any point during the talk, and then we'll have hopefully some time for questions at the end. So on that note, thank you so much, Dr. Reynolds, for joining us today, and I'll hand it over to you.
Very much appreciate the invitation. I never lose an opportunity to talk about the Kids Brain Health Network. So this is going to be fun for me as well, and hopefully for you. And let me just there we go. So I guess it's good afternoon to everybody, and unless you're on the far West Coast, it's still morning. I'm James Reynolds. I'm really happy to be here with you to give you some of the history and accomplishments of the Kids Brain Health Network from my perspective, largely. I'll make that declaration up front. So I don't have any conflicts of interest to declare, although I can't promise not to insert some of my own personal biases and attitudes. I'll try not to get up on a soapbox too often, but I do tend to go off on tangents at times. So the Kids Brain Health Network was established in 2009 as one of the networks of centers of excellence. It was called NeuroDevNet in its first iteration, and we rebranded ourselves as the Kids Brain Health Network in the second cycle of funding. The vision of the network is that all children living with neurodevelopmental disabilities enjoy good quality of life, inclusion in all aspects of society, and reach their full potential. And this is a vision for the network that really has persisted from the earliest iterations, meetings that were held in 2010 as the network was coming together and launching. This really has been the purpose for the network since its inception. The plan for realizing this vision is to catalyze evidence into collective action. And doing this requires KBHN to work with communities and partners to mobilize knowledge regarding early identification of children with a neurodevelopmental disability, introducing effective interventions when and where they're needed, and improving the system of supports for families. And these collectively should empower children and families to reach their full potential. Now, these are, of course, high-sounding, laudable goals and methods. But what does that actually look like in reality, in action? So I thought I'd sort of ground this a little bit in my own experience, because I'm a basic biomedical scientist by training. As Pam said in my introduction, I started life as a basic scientist, and much of my early work was concerned with discovery basic discovery research using animal models, molecular biology, and other such approaches. But it's probably around 2000, and I remember clearly because at that point I was involved with a startup company at Queen's University that was trying to develop new drug candidates for neurological disorders. And that experience, plus my own, I guess, epiphany at the time was how difficult it was, and in fact, how poor our track record was in the translation of scientific innovations into actual improvements in care for the children and families that we thought we were working towards. And so that really started me on my own personal journey along this path of of trying to figure out how to move knowledge, new discoveries from where they're created and get them into the hands of the people who actually need them and can use them for their intended purpose. And that's turned out to be a very long journey, filled with a lot of mistakes along the way. Uh, but I think we're getting closer. We still have a lot of work to do, but getting closer to a model in which this knowledge to practice gap can actually be overcome. And part of that was adopting what is illustrated here as the co-produced pathway to impact. And this was a framework that was introduced actually partly by David Phipps at York University, who was originally came on to the Kids Brain Health Network as a board member, but then also then became the lead of our knowledge translation core for part of the network's journey. And this framework describes a process in which the various phases of research through to the dissemination of outputs, the uptake of that knowledge, the implementation of knowledge into practice, and measuring the impact don't happen in a linear process. They happen in a circular feedback loop that involves more than the academic researchers. It has to involve those end users, ideally, those end users or core production partners from the earliest stages. And all of that, the research questions, the methodology, the goals, the objectives of the work need to be informed by stakeholders who have told us what it is they actually want or need, and then we use that information as a guide to what we do. Put more simply, and I'd like to reduce things to their simplest so that I can understand them. If we want our research to live with the children and families that we're trying to help, we have to understand what it's going to look like when it's in their hands, when it's in their life, when it's in their environment, not when it's in ours, because we can control it when it's in ours. But what will it look like when it's in theirs? Will they understand it? Will they be able to use it? Do they even want it? Knowing these things at the beginning is key. It's fundamental to the success of walking along this implementation pathway to bringing research innovations to life for children and families. And the reason I harp on this so much is we've been very bad at doing it for a very long time. And the result of that being the vast majority of scientific innovations never reaching patients or their intended audience. And we have to do better. So adopting this framework across the entire network has been fundamental for the last 10 years. All right, so what does this look like in practice? So I have a couple of examples of programs that the network has supported over the years, and I'm going to walk you through two of them. Here's, again, my own bias showing through here. These are two that I've been involved in and have the greatest personal knowledge of, so they're the easiest for me to talk about. There are many more examples that are similar to this in the network, and if you'd like to have myself or one of my colleagues back at a future date, we'd be happy to share some of those additional stories. But this one, this first study, or this case study picked, is about early life experience. And this comes from the knowledge that lifelong health is determined by more than just the genes that we're born with. And in fact, the early life experiences that we all go through in the first few years change in measurable ways the way the brain and other body systems function. And that these changes make us more or less vulnerable to health problems throughout the lifespan. This is one of my favorite pictures. And if you remember only one thing from the information I share with you today, I hope it's this one. These are MRI scans of the human brain through the first few years of development, from early after birth through the first year of life, to 2 years of age, up to age 10. By age 10, the brain has pretty much achieved its adult size. But I think you can easily appreciate that over these first few years of life, there's an enormous amount of growth and development going on in the brain. It's enlarging in size. More neurons, brain cells, are being generated. And these cells in different regions are actually starting to connect. And these various white matter, these lines of lighter colored matter that you see, these are these pathways, these connections, often termed the wiring of the brain, that allows different parts of the brain to interconnect and to function as an integrated unit. At no time in human development is the pace and complexity of brain development greater than during the first few years of life. So, put another way, the brain is not structurally complete at birth. In fact, nature has given children the chance to adapt to the specific needs presented by the environment in which they have been born. Because what drives much of this brain development and how efficient it's going to be, and therefore what skills and capabilities we have, are driven largely by the external environment. So structural and functional brain development is guided by environmental cues. An infant's brain adapts to what it sees, hears, and feels. And body systems, including the brain, are mutually interactive. Environmental experience influences behavioral, cognitive, and emotional development throughout the lifespan, making us more or less vulnerable to mental health disorders, as well as a whole range of both neurological and physiological body systems. So what does this mean for young children? Because that's our focus. Well, I'm going to talk a lot about kids in child welfare because they're a particularly vulnerable population, but I'm going to extend this theme to other groups of children as well. So in 2021, there were approximately 27,000 children in Canada living in foster care. Now, specifically foster care as opposed to adoption and kinship placements. The current standard of care for these children, pretty much across Canada, does not systematically address the risk for developmental delay. And why are children in foster care? Well, the primary reasons are they've experienced trauma, neglect, or have a history of prenatal drug and alcohol exposure. And quite frequently, it's some combination of all three. So these are a particularly vulnerable segment of our population who are at risk for developmental delay early in life because of these adverse environmental experiences. But we don't systematically look for them. Children with obvious medical conditions or evidence of physical delay can be referred to specialty care, but this frequently involves long wait times. Months or a year spent on a wait list is not uncommon. Go back to that series of MRI pictures. In those first few years of life, we can't afford to wait to introduce supportive interventions for these children, because then we're losing the opportunity to take advantage of that rapid brain development, to mitigate, if not prevent, the emergence of later term disability. And communication, cognition, and social emotional development are not routinely assessed. These are core skills that need to develop early in life And doing so is much easier early in life. It becomes much more difficult to acquire these skills later in life. So let's consider Neil. Neil was admitted to foster care at birth because of his mother's use of heroin, cocaine, and alcohol. 16 months, an experienced foster parent support worker conducted an ASQ assessment. ASQ stands for the Ages and Stages Questionnaire, probably the most widely used screening tool in Canada and elsewhere for developmental vulnerability. It assesses function across 5 domains and sorry, squirrel moment, distracted by the chat. Whoops. Back to, I hope I didn't. I lost my screen. I'm sharing, I hope, or did I stop
Yes.
sharing?
No, we can still see the slide that says Neil's story at the top.
Okay, I just need to get back to it. There we go. Well, I should have done this in my office where I'd have 2 screens. I'm just going to take a moment here. Sorry, folks. So doing that, that's fine. There we go. So Neil was had a developmental screen done, and he was found to be at risk for developmental delay in 4 domains: gross motor function, fine motor function, problem solving, and personal social development. And he was also found to be struggling with mental health concerns. So Neil received the standard of care for children in the child welfare system, but a year later, he remained at risk for developmental delay in motor function, problem solving, and personal social development. And now communication skills had also deteriorated to exhibit risk of delay. So around 2015, true story, off on a tangent here. I had a PhD student who was working with me. Angelina Palazzo was her name. She was a fantastic student, and she was actually involved in one of the network projects to collect imaging and genetics and behavioral data on kids with FASD in partnership with a number of organizations across Canada. At the time, her sister, Carmela, was working with Dr. Chaya Kulkarni at the Infant and Early Mental Health Promotion Group at the Hospital for Sick Children. And Angelina and Carmela got Chaya and I together for lunch in Toronto. And after about half an hour of listening to Chaya describe the work that she was doing at IMP, I was sold that we had to become involved in this. So since 2015, I've been collaborating with IMP and Dr. Kulkarni in a number of studies. Many of them aimed at the systematic introduction of a screening and intervention program for vulnerable children across multiple contexts. And the developmental support plan is a resource that was created in response to the needs of kids like Neil that I just told you about. And it's a document that provides goals for each functional domain that's being screened for or assessed, identifies the child's strengths. So this is very much a strength-based tool, and then provides caregivers with simple strategies they use during everyday routines to support a child's achievement of goals. Again, back to that series of MRI images and what I told you about the environment being a major driver of brain development in young children. Children respond to the things they see and feel and hear on a daily basis during this period of time. And the primary caregivers are the people who have the greatest role to play and have the greatest influence on that environment. And so providing tools and support for what is the child's most effective and most frequent interventionist makes logical sense. because it gives us the greatest opportunity, the greatest capacity to support the greatest number of children possible. I don't have time to go into a lot of details about the developmental support plan, but I have put up IMP's new website, which I was on the other day, and it's fantastic. Again, with support from a number of sources, including the Kids Brain Health Network, many of the tools and resources have now been put online in a learning management system. And there's a series of also learning modules, seminars, courses, certification courses even that have been put up that I encourage you to go and have a look at. So we actually were able to do a study. We actually initially we started this as what was going to be a randomized clinical trial in which kids were randomized into an intervention or control arm. But the large urban center and child welfare agency that was going to be our partner in this jumped the gun a bit and established a policy requiring ASQ screening and a developmental support plan be provided for every child in foster care. Great for the kids, not so good for our study design, but we worked with them anyway. It's over a 2-year period, children taken into care and placed in a foster home. So this is only children who were placed in a foster home for a prolonged period of time. Were followed, and the ASQ screens were repeated approximately every 4 months. So all of the support workers, the child protection workers who were involved in this, received training in both the administration of the ASQ and the creation of the developmental support plan from infant and early mental health promotion at Sick Kids. So there's a standardization of the assessment and intervention protocol. And so after each screen was repeated, developmental support plan was either created or modified for the specific child and then put in place with the foster family. So this is data from that initial study. There were 237 children that we collected data on with at least 3 time points of collection. And at the bottom, you'll see the results of the statistical analysis. So a repeated measures analysis of variance was highly significant, and this is one of the domains assessed. It's the communication domain. And there was about equal numbers of males and females in this group, 122 to 115. And again, about 115 of the kids were Indigenous or identified as Indigenous in the record. And what you can see here is that there was a time-dependent improvement in the communication scores. So we were able to standardize each of the assessments. I should have mentioned this. The ASQ there are 21 versions of it that go between birth to 6 years of age. So there are age-appropriate questions that look for skills, capabilities in the children at different developmental stages that can be compared against a population norm. So these are standardized scores. It means a score of 0 so Z scores are standard deviations away from the mean. So a score of 0 would mean that the child was bang on average for hitting that developmental milestone. And you can see that there's a number of kids who in this population who were scoring very, very low. And so I was asked the question, well, is there anything specific going on or selective going on with the kids who are particularly vulnerable? So I separated the data out, grouping the kids who were scoring at least 1.5 standard deviations below the mean for their age, compared to those that were above that threshold. That is, the kids who were making or meeting developmental milestones according to the ASQ screen. And then I repeated the analysis, and across every domain that we looked at in this particular cohort, there was a statistically selective change in ASQ scores over time in the kids who at baseline were scoring very low. That is, they were either developmentally delayed or at risk for developmental delay in the particular domain being assessed. So a lot of other things going on in in this data. Clearly, not all children respond. So some of the kids, even though they were getting a developmental support plan, did not change over time. Some of the kids who at baseline were meeting developmental milestones deteriorated over time. But again, this is a very vulnerable population. And other than being tracked and having a developmental support plan, we had really no knowledge about what else was happening with this particular group. But anyway, initially, very promising results that simple intervention introduced in the home could have a positive effect on the developmental status of these kids. So can we change the narrative? So this is Sadie's story. Sadie came into care at age 21 months. She was prenatally exposed to alcohol and drugs. She experienced domestic violence and was physically neglected. Sadie was placed with a foster mother who had completed training in infant mental health. And again, ASQ assessments were done at the beginning when she first came into care, and they demonstrated risk of delay in multiple areas of function: communication, motor function, problem solving, and personal social development. And a concerning score of 135 on the second assessment, the ASQ SE2, which specifically looks at social emotional development. And the higher the score in this assessment tool, the greater is the concern. So a developmental support plan addressing these areas was put into place, was followed by the foster mother, and supported by the child's worker. Less than a year later, Sadie was meeting developmental milestones in all areas, and her social emotional score had improved to 70. Should say that one of the other things that happened is that Sadie's biological father, who came to access visits with Sadie over the time, noticed and was encouraged by the obvious changes in his daughter. He himself cleaned up his own act and was actually able to regain custody of Sadie at a later date. So we can change the narrative if we look for the problems and we put the appropriate supports in place. So what do we know from this? Developmental delay is very common in young children in child welfare system, but not just there. There are other vulnerable populations of Canadian children in different regions and in different contexts. In fact, it's been estimated that 25% of Canadian children reach school age with at least one domain of function that is developmentally vulnerable, if not delayed. But it appears that these developmental delays may be responsive to a child and caregiver-centered intervention. Current work that IMP is involved in and that the network continues to support is aimed at spreading and scaling the intervention to other populations and communities. And in fact, we were able to leverage much of the work that was done earlier, some of which I described to you and other parts of the project, to obtain a 5-year CHR team grant under the Mental Health in the Early Years Initiative. And this is specifically aimed at the implementation of the infant and early mental health care pathways in multiple communities and regions across Canada. And again, this is my bias. What does success look like? One of my students sent me this, who's remained involved in this project, sent me this link a few weeks ago. Algoma Public Health is responsible or provides public health across a great chunk of northwestern Ontario. And they are one of the partners that have signed on to this project and are implementing the care pathways in multiple community organizations across the region. And why I put this up, and if you have the opportunity to read the article or listen to the interview, it's less what's there than what's not there. And what you won't hear in this interview or in that article, you won't hear the voice of an academic or a researcher talking about a program that they developed and is going to be introduced in a community. What you will hear are the administrative and clinical leads at Algoma Public Health talking about what they're doing, how they're leading, this initiative in their communities and providing this support, and how excited they are, not only to incorporate this programming into the system of supports they provide for children and families, but also how excited they are to contribute the information, the data they're collecting into a larger collective of partner communities and organizations across Canada who have all agreed to put outcome data from this initiative into a common database that is going to serve as a resource that will, for perhaps the first time, allow us to talk about the developmental status of Canadian children on a population basis. Okay, so I'm going to shift gears to another study. And this is another project I've been involved in, but it started actually at the beginning of COVID. And in 2020, as you'll recall, there was abrupt withdrawal of services, social isolation, in-person contact was simply no longer allowed. And for families that had depended on programs of support, this was potentially devastating. So KBHN and MITEX co-funded a series of Accelerate internships to work with community partners across Canada to investigate the impact of COVID-19 on families raising children with neurodevelopmental disabilities. And particularly, one of the questions was whether, in fact, online remote service delivery could continue to be effective. But what we found was that several of these studies revealed an exacerbation of violence and aggression in the home as a direct consequence of the abrupt withdrawal of services and supports for these families caused by school closures and lockdowns. And some of the stories that emerged from this were truly devastating. Aggression in the home by children towards their caregivers or other family members doesn't happen in a vacuum. There's frequently coexisting neurodevelopmental disabilities and other related conditions that contribute to or make these children vulnerable to expressing themselves, using aggression as a way of expressing themselves or communicating. So this is like the bell you can't unhear. When you hear these stories, when you hear the problems, when you hear the cry for support, and it really was a cry for support, because during this time, families who faced escalated aggression in the home, who contacted any agency or support, were told that their only options were to call the police or to give up custody of their child into the child welfare system. Neither one of these were very desirable actions or options for families. As they expressed over and over and over again, they did not want to break up their family. They just wanted to feel safe in their home. And so that's the need that we tried to respond to. So KBHN worked in partnership with Interwoven Connections, which at the time was a call for Adopt for Life. And they're the largest not-for-profit organization in Ontario supporting foster kinship and adoptive families. And we worked with Interwoven to support the first ever National Consortium on Aggression towards Family and Caregivers in Childhood and Adolescence, or AFCA. And a lot of thought and discussion went into the name, which I really don't have time to go into, but as much of a mouthful as it is, it took a long time to come to agreement that this was the best title that we could give this phenomena. The group conducted a national survey and stakeholder consultation, and that in turn led to a comprehensive report and set of policy recommendations. And I've given you the website there because it is, in fact, a very comprehensive report. And policy recommendations came at multiple levels, from federal to provincial governments to community organizations, and how best to support families. This was, again, the first time that this type of work had been done in such a scale, involving input from families, from youth themselves who had experienced or perpetrated AFCA, uh, as well as the various levels of support organizations and even government representation on the consultation. And one of the outputs, one of the outcomes from this work was that in 2022, the Ontario Ministry of Children, Community and Social Services awarded a 3-year contract to Interwoven Connections to develop and implement the novel AFCA Family Supports Program. And again, this was the first of its kind in Canada. It was meant to bring into play all of the information that had been garnered in this consultation and other work. And just sort of to complete the circle, the PhD student and my tax intern who was involved in one of the studies that revealed this phenomenon, Maud Champagne, um, was hired when she completed her PhD, actually just before she completed her PhD, to develop and run this Africa Family Supports Program. And the program itself is multifaceted because the problem itself is multifaceted. And different families going through Africa experience different levels of severity and need different approaches, different types of support. Some of this involves the creation of peer communities and clinical coordination, clinician-led therapeutic support groups for parents and caregivers. And one of the other innovations, Mode in particular, went out and researched what was available worldwide for this program. And there's one clinical therapy called nonviolent resistance therapy, or NVR. It's the only program or intervention we could find that actually had gone through rigorous clinical trials to demonstrate its benefits or its impact to mitigate the effects of AFCA. We actually sponsored the first clinical trial. We found one of the leading purveyors, actually, of NVR in the world is Partnership Projects in the UK. And we contracted with them to deliver the first AFCA support or NVR support program in Canada. So the therapists themselves were in England. The families were here in Canada. It was very challenging for a number of respects to do this, but it launched us along this path of introducing innovative and evidence-informed clinical interventions for this program. There's a number of other levels of support, both clinical support and peer support, that goes into the program. And over the 3 years, the program supported close to 700 families experiencing AFCA in Ontario. So what did the families say about it? Well, they reported improved caregiver knowledge and skills regarding AFCA, increased caregiver ability to keep themselves and others safe, reduced aggression within the family, improved parent-child relationships. It helped the caregivers develop a better support network, which has proven to be critical, and it increased stability of the family. This is a really critical thing because when we talk about programs like this, we also have to consider not just the cost of them, but what's the return from the investment. We worked with another community agency that's tracked the costs of placement breakdowns in child welfare. When an adoption or foster placement breaks down and a child has to be moved, placed with another family, there's a huge economic cost of that. And they estimated on average, it was about $50,000 per incident. And many kids in foster care, when they're unable to have stable placements, may move 4 or 5 times in the first 4 or 5 years of life. Those are repeated trauma. Again, reference that those critical periods of brain development when the environment is driving how the brain is developing, and adversity in those early years will have a negative impact on brain development and social and emotional development in the individual. So there's a clear economic cost and a clear impact on development. But the human cost goes far beyond that. When we talk about Africa, as I said, it has various levels of severity. We're not talking about a child who yells at you or throws temper tantrums. There were actual physical harm and instances where the caregiver literally feared for their life in their own home from their child. And this was devastating. The guilt and shame that parents can experience in this situation is truly unimaginable. Um, have anywhere to go. That was probably maybe the worst. Feeling helpless and not having anywhere to go is just something we can't collectively as a society accept. So the interwoven connections through this program has developed a home, a destination, a system of supports that families respond to. It's created a community of practice for parents and families where they can connect with other people, other families that have gone through similar situations, where they can realize that they're not alone and they're not going to be judged. And where we know for a fact that in the absence of these supports, the likelihood of individual families staying together was incredibly low. So I will stop there and I will be happy to take any questions or comments from anybody who's on the line.
Thank you so much,
You so
James.
much, James.
We have a bit of an echo on the line now. And we're happy, I'm keeping an eye on the Q&A. And so maybe as people gather their thoughts and think of something that they want to put into the Q&A function, I think I really appreciate you sharing some of the work that you've been involved with. And I think some of those topics are really challenging, right? Like really challenging things for families to be able to talk about, to seek help about. And I imagine there's a lot of interplay of stigma and anxiety and asking for help on some of these things. And certainly as somebody who does brain health related research on the other end of the aging spectrum, I appreciate that during COVID, so many resources for people in their homes just disappeared. And it was incredibly challenging for families to be able to try to continue caring for people in their homes. So I work with people living with dementia, right? And so we sort of saw similar experiences there. Maybe just to get our questions rolling, I'll ask the work that you do. I can see so many different implications and policy implications for things like in school supports, social care system. And so just curious about how you move the work or how you would work with others to make those sort of policy impacts down the line.
Well, that's why we have Jennifer. And uh, I mean, it's a great question, and this is again part of the learning. Um, you know, go back to and many of us were guilty of this, and I put myself in this camp that we had this concept that if we built something, of course, it would be used, and the value of it would be evident, and people would beat a path to our door to use our thing that we created because it's good for them. Well, we all know that doesn't happen, and working with decision makers, one, to not to skirt around your question, but involving those decision makers again at the earlier stages, they need to be part of those stakeholder groups. The co-production involving them at an earlier stage so they understand what's happening. They see the value. We actually had a member of the Ministry of Children and Community Social Services on the panel as we were developing AFCA, as we were looking at the results of the consultation, as we were hearing the stories coming from individuals and families. There was a member of that ministry who was hearing all of those things at the same time we were. I think that line of communication was absolutely critical in their decision to put money into this program. Now then it's on us and with the program, and we worked closely with Interwoven on to ensure that there was an evaluation framework associated with this program, that we were going to collect information on impact that could go back to the funders, the sponsors of it, so that we could demonstrate the return on investment, the improvements in outcomes for them. And then we have to follow that up with personal communications. We have to be part of the collective voice, not just with the organizations, but we need to lend our voice, our knowledge, to theirs on the value of these programs. And when I look at this, and we've all been part of these conversations where we will fund something for a year or two, and then it'll simply die away because the value of it, the return on the original investment has not been made clear. And so where's the argument for continued investment? The sustainability of these programs means we need to understand who needs to be involved, who needs to be informed, and when they need to be informed about what's happening. It's all part of the learning and mistakes that we've made along the way that have given us this more comprehensive framework if we want to have the impact that we say we want, that we're aiming for.
Yeah, absolutely. And that's important things to think about to make sure you have that buy-in along the way as well. I do see a hand up, but we have a couple of questions that came through the Q&A first, so I'll just jump to those. There's a great question here around the developmental support plan and the training required to use it. So does it require specific training, or is it something that could be used by community and organization staff to work with families that they see?
Yeah, great question. Thank you for that, because that is the intended argument, or sorry, audience for the program. It does require some training. Infant and Early Mental Health has designed both in-person and online training in both how to do the screening assessments and how that feeds into the developmental support plan. It's a very simple tool to use, and it's in it's very visual. It's in the language of the child, and it's again strength-based. And it's not about what the child can't do. It's what they can do in the moment when it comes to these skills, such as communication. How many words should a 1-year-old have or a 2-year-old have? And how frequently do they use those words? And it's knowing where they are then defines the next developmental milestone that is going to work with. And then the simple strategies, 2 or 3 things that can be incorporated into the family's daily routine to stimulate those. It's meant to be used by anyone who comes in contact with these families. Just as an example, workers in early on centers, daycares, perfectly positioned to use this type of tool. The training itself it's not extensive, and there's ongoing then coaching and support provided by IMP for these programs. We now have I think probably somewhere around 800 or 900 frontline service providers across multiple types of agencies, both in public health and in child welfare, who have now engaged in the training and are incorporating this program into the work they do with families on a daily basis.
Thank you so much for answering that. And the same person kind of put a comment in that's in the Q&A, so not everyone can see it, but I'll just read it out, that idea of having primary caregivers realize their own capacity in strengths-based ways to be able to provide supports is really powerful, right? To help families be able to access different services. I'm just going to point out quickly, we do have the unmute function disabled right now. So for those of you with your hands up, if you just put your questions into the Q&A function, we can definitely bring them to Dr. Reynolds' attention. I'm going to ask a question that's been proposed that the asker recognizes might feel a little tangential, but I think while you're with us, I wanted to ask a question around screen time and in those key parts of brain development, and we're seeing increasing use of screen time, just sort of the potential impacts of that increased screen time for children.
Oh, I'm so glad. Thank you for that. It is not tangential. It is actually incredibly relevant. So the concept of the environmental stimulus provided by caregivers is based on the serve and return model. And this has been studied extensively. The Harvard Center for the Developing Child has probably got the best resources on how this works. And it means that for a child's action, there needs to be a reaction. Then that is how they learn. When your simplest example, again, I'll revert to my own experience when I come home and we'd sit down for dinner with our son when he was a child, and he's sitting there beside us in his high chair and slams the table and makes ba da da ba da ba da, whatever sound comes out. When we would turn to him and say, "Really, tell us more," that's the learning moment. That's when they're realizing that when I do something, I get a response from my favorite toy, which at that point would be the primary caregivers. You're not going to get that from a video. Sorry, there is no interaction there, and so you miss the richness of that interaction, which is the true driver of the neural circuits that will underlie the skill that's involved. In this case, it would be communication skills. It requires that feedback from again the people, or from all the people that the child comes into contact. The ones that they're in contact with the most have the greatest opportunity and the greatest potential to affect that trajectory of brain development.
Fantastic. Thank you so much. And so interesting to think about all those little things that we do as caregivers, right? I think we have time for one more question. So I'm going to ask this one because this is something that occurred to me. And it's important to think about when we think about social systems and child welfare and foster care and the disproportionate representation of, for example, Indigenous children in those systems, and other groups too, right? So I was actually curious, and I was going to ask, so I'm glad this came up, if there is current work going on or future work planned around culturally specific adaptations to some of the programming.
Thank you for that. And the answer is yes. We have actually several parallel projects going on. I talked about developmental support plans. The first one that was created, the resource was called Hand in Hand. And this goes back well over a decade. But IMP recognized very, very early on the need to consult with Indigenous communities across Canada in what would work for them. And so there was a committee of elders from, again, across Canada that worked with IMP on adapting the intervention for Indigenous communities. And it's called Nurturing the Seed. Kids Brain Health Network has supported that project for several years. It's still going on with continued funding from the Public Health Agency of Canada. we had a meeting about it yesterday. We have about 11 Indigenous communities across Canada that are part of the collective that are using Ages and Stages questionnaire because it also has been validated in multiple languages and cultures, including Indigenous communities in Canada, because the tool itself, the screen can be adapted, the questions can be adapted for the local culture. It's a very simple thing, relatively simple thing to do. And then the developmental resource, the planning tool was also adapted with extensive consultation. So that is actually going on right now. There's probably about, if I remember correctly, they said there's about 400 service providers in Indigenous communities and different parts of Canada that have taken the training and are using the approach in their practice. About 100 or so of them have actually agreed to be part of the research study in which we're collecting information data on children and families. To date, one of the biggest impacts has actually been on the caregivers themselves. And one of the tools we used was the parental stress index. And unfortunately, this study started in the fall of 2019. And I guess like we all know what happened in the spring of 2020, which had a fairly massive impact on this research program, as did many others. But the communities wanted to remain involved, so they re-engaged with us at later dates, and the project is still ongoing. It's incorporated. It's also supported, I guess I should say, by the CIHR grant, even though it wasn't aimed specifically at Indigenous communities. There are Indigenous communities that are part of that collective. And that the reason that we can do that is that the program, the power of decision making actually resides at the community level. They decide how they are going to engage with us, and we work with them in evolving a plan for incorporation of both the training, the intervention, and the eventual data collection that fits within their structures, within their local communities. So the cultural adaptation continues. It's not something that's a static process. We're constantly learning and adapting and being informed by our community partners wherever they are about the impact of the program and how they're receiving it and how we can do better. And by listening to them, I think we've created certainly more trusting relationships and partnerships, what I call true partnerships, because they are invested with us in helping to support the kids and families in their communities.
That's fantastic. Thank you so much. And as somebody who also works on adapting sort of brain health assessment tools for Indigenous communities, I really appreciate the distinctions-based approach and doing it community by community, which is a huge and important process. So I appreciate you sharing all of that. Thank you, everybody. Thank you, Dr. Reynolds, for joining us today. Thank you to all of you who joined, and I hope you carry on with the rest of your day and have a lovely afternoon. Thanks so much.
Thank you very much for having me, and I very much appreciate your attention.
Thanks so much, Jane.